We probably need to catch up a little tiny bit on time. I want to start by, I'm Carolyn Freeman. I was introduced to you yesterday. I am very pleased to have been invited to participate in the organization of this meeting, which is very impressive. I'm enjoying it a great deal, actually, with all kinds of new ideas. So my role today is to introduce the two speakers for this next session, which is learning from the patient experience to improve care. We heard a lot yesterday. I don't think we're talking about the why anymore, but I hear a lot of how and what. Our next two speakers will describe their work, one from the US and one from Montreal. The work that entrenches the patient's perspective in the design and delivery of healthcare. So our first speaker is Monsieur Vincent Dumez, who is co-director with Dr. Paul Lubel of the Office of Collaboration and Patient Partnership at the University of Montreal. Correct? Correct. Okay, fine. At the University of Montreal's Faculty of Medicine. This is an innovative program that has really led the way in this field in Quebec. And they now have some 50 patient leaders who participate, for example, in training medical students and interprofessional teams, with the goal of cultivating collaborative practice that includes patients as full partners and increasing patient capacity for self-care. So the program that actually only started in 2010, as I understand it, is now active in more than 10 healthcare establishments in Quebec, and it involves some 25 healthcare teams. So they have a lot of collaborations, including with our own Montreal Neurological Hospital. Monsieur Dumez is working with Mario Di Cali, who you met earlier, on a CFHI-funded project at the Neuro. Following Mr. Dumez, we're going to hear from Dr. James Malino, who's a practicing colorectal surgeon at the Cleveland Clinic. Dr. Malino is the founder and current president of the Association for Patient Experience, and in 2013 was named Health Leaders Magazine's list of 20 people who make healthcare better. The Cleveland Clinic was the first major academic medical center to make improving the patient experience a strategic goal, and the first to embed an Office of Patient Experience into its leadership structure. The office serves as a resource, an advisory resource for critical initiatives throughout the institution. Dr. Malino is the Chief Experience Officer at the Cleveland Clinic, and today is going to tell us about the impact that the office has had on the clinical staff, on the culture of the health center, and on measures of the patient experience of care. And hopefully we'll have some time after the two presentations for questions. So I'd like to invite Mr. Dumez to start off.
The first reason I'm here, actually, it's because I'm an experienced patient. So, and that's the first characteristic of the Montreal University initiative in terms of patient engagement, is that patients were invited to lead a patient partnership program building from inside the Faculty of Medicine. So it was a huge step. Maybe we think it was the first time in the history of a Faculty of Medicine that patients were invited and put in place with a leadership role in order to promote the patient perspective vision inside the institution. And today, the model, as you can see during my presentation, has evolved because I'm a co-director of this unit with a doctor. So we are co-leading the unit together now. So, you know, I'm an experienced patient. I'm a severe hemophiliac, so I've been living during 44 years with my doctors and nurses and all my clinical team. I've been blood contaminated by AIDS and hepatitis C in the early 80s. So, as you can imagine, I know a little bit about hospitals and clinical. And I was an aid activist in the end of the 80s, starting 90s here in Montreal. I've been a management consultant for a long time also, a strategic management consultant and a project developer. So about 5 years ago now, the Dean of the Faculty of Medicine of Montreal University, Dr. Jean Rouleau, invited me to start this initiative. And I remember very well how it happens. I mean, I was in his office and he had the first version of the SPORE document, you know, Strategy for Patient-Oriented Research of the CIHR. He had the first version of the document and he threw it on his desk and tell me, you know, Vincent, the CIHR just produced the first version of a strategy for patient-oriented research and no patient were involved to define this strategy. And I remember very well, and he looked at me and said, we need to have patients inside the Faculty of Medicine in order to change that. And so you're going to have a unit, you're going to be funded, you're going to be legitimized, you're going to be on our governance, and so on. So it started in September 2010. Why? You know why Dr. Ross Baker told us a little bit about that. It's time for doctors to change. You know, we know where one of the big power in hospital is. I mean, we can talk about patient engagement, patient partnership as long as we want. If doctors don't engage also, it's going to be worth it. It's not going to be worth it. We know that. So, and I think Faculty of Medicine are ready to move today and are ready to rethink about collaboration practices of their students, like we can see in this editorial in the BMG. And they want to move because, as you know, 50% or more of the population have a chronic disease today, and it's a reality for our doctors. We can't train anymore our doctors to be efficient, you know, to cure, because they're not going to cure the majority of their patients. And what we know in medical school now, it's a source of frustration for them. So we have to change the way we teach them collaboration, communication, professionalism, so it changed a lot of things. You know, with the first time, in the first year, I arrived, all my doctors, colleagues were telling me at this moment, you know, Vincent, the huge problem we have today is that patients don't arrive in our office with symptoms anymore, but with diagnosis. So the 5 minutes is getting very long. So we have to understand what it means for us and what it means in terms of collaboration. So it's very simple example, but just imagine what the consequences on the way we train our doctors. We know also that a lot of individual patients today are struggling. The non-compliancy numbers, you know them very well. And we just can't say it's because of patient non-responsibility. It's also a huge challenge for health professional practices to understand why, how they can help to manage those results, and how we can make sure that patients are well accompanied in healthcare setting, but they know also how to take care of themselves outside clinical settings. And also everything is changing because patients and families have access to information. And, you know, it's not a choice. It's happening. It's a reality. So health professionals, hospitals, university faculties, they just have to face it. I mean, we're not going to go back on that. That's why this change is very different from this kind of change we had in 20 years ago. This one is a real one, and nobody's going to come back on that. 90% of the population are systematically going on the net before meeting their health professionals. It's a very important fact, and when people say, yeah, not all patients want to be partners, look at that number. I mean, it's a huge proportion of the population. So when we arrived, patients and family members inside the faculty, first of all, I was the only one, and very quickly we were 12. We constitute a faculty expert patient committee. So, and we began to discuss with our educators, colleagues, about the vision of collaboration. What kind of vision of collaboration we're going to push forward in the Faculty of Medicine? And we agreed that it wasn't paternalism. We want to turn the page definitively on paternalism. We agree patient-centered care was a great approach and it has to be strengthened because it's not a reality, as you say, Dr. Baker, in most of hospitals today. We talk a lot about it's a branding for many hospitals, but it's not a reality on the ground. But what our patients and family said was, why don't we push a vision where we can imagine the patient not only in the center, but inside the care team, considered as an actor of care. Because that's what patients and families are, actors of care. If you, Angela Coulter, a researcher in Britain, just said recently, in a year, a patient with a chronic disease and his family, plus his family, is going to spend 5 to 10 hours with their health professionals, and they're going to spend 6,000 hours in the same year taking care of themselves. Okay, and the focus of the system today is on the 5 to 10 hours. And not very much on the other side. So that's now today the circle with the patient inside and with this concept of factors of care is at the heart of the teaching of the University of Montreal Health Sciences program. Patients have been pushing on that. Patients have been involved in the redesign of the program for the first, second, and third year of training of the 13 disciplines of health sciences. So that's what the first piece, patience in leadership and a shared vision of collaboration. And now we push together in this direction. It was important also for our students because we have a huge problem of loss of empathy for medical students. I mean, it's a reality. I mean, there was this article written maybe 3 years ago called The Devil in the Third Year. And there was many articles after that which show very dramatically that 70% of our medical students lost empathy starting the third year. We have a problem on how we teach collaboration and communication. A lot of skepticism, communication issues, new collaboration challenges. So there are many issues to face in care, and we have to help our students to face them. It's a responsibility we have as a university and a faculty. So that's how why we did that. So Jean Rouleau did the thing very well. He said, okay, the faculty and Dr. Hélène Boisjoli today has taken the lead also, so we have a continuity in terms of leadership. The Faculty of Medicine said, okay, we're going to build on the vision of partnership in care. Yes, we're going to introduce patients at the different level of the faculty. So we are on the main councils. We are in leadership position on all the committees with an added value. We structure the patient engagement program. So we've been growing. We're not only 50, we're 175 today. Patients as trainers, teaching collaboration, communication, and ethical ethics to our students. We've been putting in place selection process, training process, and the secret of that is very simple. Patients are co-leading. Patients are now selecting, recruiting, and training other patients. And I can tell you that's very, very efficient. But it's a hard move to make also because it's a very important cultural change in order to get that. But we had the chance to realize that and to prove now it's very efficient. So that's how the Faculty of Medicine managed the patient engagement, patient partnership change during the last 5 years, and we are very proud of that. So on what kind of subject we're working on today? We try to move forward on the MD and postgraduate program, developing students' capacity to manage growing human complexity, facing challenging societal issues, also reinforce partnership with their patients. We work a lot on some longitudinal competencies as collaboration, communication, and professionalism. Our patients and families are systematically involved in this thinking and in the delivery of those formation training. And we involve patients at the different steps of the organization. So today, what are we? We have an operational team. Co-lead by a patient and a doctor, constituted of patient experts, researchers, health managers, health professionals, dedicated to co-building and creation from experiences of all the partners. So we are living partnership on a day-to-day basis in our team. And I can tell you it's a hell of a challenge sometimes. So we are learning from the way, and I think that's the secret. The secret is not to invite patients to come at one moment, and then it's to have them in the operational functioning of the system. So that's what we are experimenting right now. We have great researchers also, and I see Marie-Pascale here today, who are involved now, who've been involved for many years now with us to help us in research, also to help us develop our evidence-based results. So what the scale of the program is 120 patients as trainers, involved in programs transformation, students training, students mentoring. So we have also, as we have some patients who are mentoring health sciences students. We started that last year. We have a lot of demands from healthcare setting. We are accompanying now 24 hospitals in Quebec to involve patients in health quality improvement processes. Lean is one of them. It's a huge amount of work for us, but we've been working already with 26 clinical settings, and it's been a great success. We work also with the Ministry of Health, and I see France here, and we had many discussions on the quality policy of the Ministry of Health. And so it was a great opportunity for us to understand the challenges we were facing to involve and engage patients in hospitals. And the chance we had is that we did our experiences in every kind of clinical settings: geriatrics, pediatry, mental health, etc., etc. So we've been proving for the last 5 years that it's possible in every kind of clinical setting. The methodology is changing a bit. The approach is not the same. The way the patients are engaged or involved in quality improvement, and sometimes it's a little bit different, but it's working, it's worth it. It's difficult, it's very difficult. One of our team here at Shawinigan is here, and maybe you can testimony that sometimes it's difficult. But when it works, I mean, it's viral. Nobody wants to stop. Everybody wants to go further and to multiply the experiences, because we know, as showed presenters before, it's very worth it. And we've been working, and I will finish on that, with the CIHR for the last year and a half now, 2 years. And I see Mireille was a part also of the thinking team on the public and patient engagement strategy. So they seem very serious about that. So it's good news, very good news. I think they're very much convinced that we need more patience on research governance, and so we have the chance to accompany, actually right now, 3, maybe 4 Canadian research network, in order to help them engaging patients in their governance and in their project. So arrhythmia, intensive care, and transplantation. So it's initiative we're just starting. We're just starting, but the first experiences we did were amazing. Amazing. In transplant, we had a meeting with patients and researchers in Montreal in August. It was 3 hours of co-creation and co-building, and everybody was so happy at the end of the work session. So it's a huge trend, as you can see, in the States, in Canada, in Europe. We don't speak a lot about Europe, but many things happening in Europe also. We are very close to researchers in France, in Belgium, in Switzerland. So it's a huge trend, and the key success factor of what we did during the last 5 years was patients were inside. Patients were co-leading. If we want that to work, we have to be courageous, don't be afraid of each other, and believe that co-building is possible, that we share responsibility, that we share risk at the level of the care process, but also at the level of the functioning of the healthcare system. So it's time to work together and to understand more and more how it works and the complexity of it. But the good news is when we have the first success, we don't want to stop anymore. So as a patient who lived a difficult situation 30 years ago when I was blood contaminated by AIDS, today I'm very happy and I have a lot of hope, even if sometimes our healthcare systems are not going very well. I'm very hopeful for the future because of that. I think that's the solution to huge problems we have today. So let's work together. Thank you very much.